Hello everyone and welcome to my presentation. I am Asmaa Elkasabi and we are going to talk about subarachnoid hemorrhage, what should you know, and the role of radiology. It is super important topic, so let's start. Learning objectives of the lecture. We will start by discussing what is subarachnoid space. Then we will talk about where does the blood accumulate and why this happens, what are clinical presentations of patients with subarachnoid hemorrhage, and finally we will talk about how can we diagnose subarachnoid hemorrhage, specifically imaging features. Before we talk about subarachnoid hemorrhage, what does subarachnoid mean? Sub means under, so subarachnoid space is under the arachnoid matter. But what is arachnoid matter? Let's take a coronal section of the brain and zoom in to take a closer look at the meninges. As we see here, the brain is covered by three meningeal membranes, from outside to inside. The first layer is the dura mater, which is represented in light blue color here. Then the second layer is the arachnoid matter, which is represented in pink color here. And the innermost layer is the biomatter, which is represented in yellow color here. Arachnoid matter, as we can see, forms the middle layer of the meninges and gets its name from the web-like appearance. After we discussed what is arachnoid matter, so what is the subarachnoid space? The subarachnoid space is the space between the arachnoid membrane and the biomatter. It contains connective tissue trabeculae, cerebrospinal fluid, and branches of the brain vessels. You can see here there are two green lines close to each other. The outer one is representing the arachnoid matter and the inner one is representing the biomatter. It is important to know that arachnoid matter doesn't enter the sulci or fissures except at the great longitudinal fissure between the cerebral hemispheres. But the biomatter follows the gyri and sulci. Where does the blood accumulate? In subarachnoid hemorrhage, you will see blood accumulates in peripheral extension around the surface of the brain, in subarachnoid cisterns, also cerebral convexity or cortex, which means you will see blood at the gray-white matter junction within the cortex. In subarachnoid hemorrhage, you could find one or more of these sites in one patient. In this diagram, there is peripheral extension of subarachnoid hemorrhage around the surface of the brain. As you can see, the blood here follows the gyri and sulci of the brain surface. This appearance is characteristic for subarachnoid hemorrhage. So, what about subarachnoid cisterns? Cisterns mean box. They are boxes filled with CSF. We can see here examples of subarachnoid cisterns in this sagittal image of the brain. A. Cistern of lamina terminalis, which is superior to suprasellar cistern and anterior to the third ventricle. B. Suprasellar cistern, which is superior to the sella and around infundibulum. C. Which is anterior to the midbrain and called interpeduncular cistern. D. ambient cistern, which is lateral to the midbrain. E. Quadrigeminal cistern, which is surrounded superiorly by splenium of corpus callosum and inferiorly by the superior border of cerebellum. C, D, and E. Interpeduncular cistern, ambient cistern, and the quadrigeminal cistern are called perimesencephalic cisterns. These cisterns are surrounding the midbrain. Also, we have here F, which is cerebellopontine cistern. It is lateral to the bones. G is prepontine cistern, which is anterior to the bones. H, cerebellomedullary cistern, which is lateral to the medulla. And finally is the biggest subarachnoid cistern, which is called cisterna magna, is located posteriorly to the medulla. Risk factors include: they found subarachnoid hemorrhage slightly more in women. One of risk factors is presence of first-degree relative had subarachnoid hemorrhage. Also, hypertension and excessive alcohol intake have associations with an increased risk of subarachnoid hemorrhage. Subarachnoid hemorrhage is found more common in African people compared to other ethnic groups. Also, abnormal connective tissue disease is a risk factor, as connective tissue is important for the integrity of the blood vessel wall. Why this happens? Subarachnoid hemorrhage can be traumatic, which is the most common cause, or can be spontaneous. The spontaneous or non-traumatic causes, by far the most common cause is ruptured perianeurysm, which represent about 80% of non-traumatic causes. Also, perimesencephalic hemorrhage, which represent about 10%. As we said, it is hemorrhage in subarachnoid cisterns around the midbrain. The origin of perimesencephalic hemorrhage suggested to be due to venous or capillary rupture, which has better prognosis than cerebral arterial aneurysm. Other causes include ruptured arteriovenous malformation, cerebral amyloid angiopathy, which is the most common cause of cerebral convexity subarachnoid hemorrhage in elderly patients. Also, reversible cerebral vasoconstriction syndrome, which is the most common cause of cerebral convexity subarachnoid hemorrhage in younger patients. Cerebral vasculitis, and using sympathomimetics drugs or anticoagulant therapy are other causes. As we discussed, ruptured perianeurysm is the most common cause of non-traumatic causes. It is due to deficiency in arterial wall strength, which made the wall liable to formation of aneurysm, so easy to rupture and bleed. We see here the circle of Wills, which includes anterior circulation and posterior circulation. The most of perianeurysms arise at anterior branching points along the circle of Wills. It is important to know that 90% of these aneurysms are found in anterior circulation, and anterior communicating artery aneurysm form about 30 to 40% of the anterior circulation aneurysm. What are clinical presentation of subarachnoid hemorrhage? Patients typically present with sudden onset thunderclap headache. Patients will describe the headache as worst ever headache of their life. It is important to remember the typical presentation of subarachnoid hemorrhage. What else? About 80% of patients with subarachnoid hemorrhage will present with meningeal irritation symptoms, as neck stiffness, neck pain, and photosensitivity or sensitivity to light. Also, the headache may be accompanied by nausea or vomiting due to increased intracranial pressure. Also, focal neurological deficits may occur. About 45% of patients will present with transient sudden loss of consciousness. Also, patients may present with stroke symptoms, especially after days, due to insufficient blood supply of the affected areas. How can we diagnose subarachnoid hemorrhage? Specifically, we will talk about imaging features. The diagnosis of subarachnoid hemorrhage usually depends on clinical suspicion combined with radiological confirmation by doing urgent brain-computed tomography scan. If CT scan is negative, what we can do? It followed by lumbar puncture to detect the presence of blood products in the CSF. After the diagnosis of subarachnoid hemorrhage is confirmed, further imaging should be performed. Why? To characterize the source of hemorrhage, as doing CT angiogram, MRI angiogram, and digital subtraction angiography. Don't worry, we will talk about that. So, what about imaging of subarachnoid hemorrhage? CT brain without contrast is the first imaging study we usually do when suspecting subarachnoid hemorrhage. It is widely available and highly sensitive to rule out subarachnoid hemorrhage, especially within first 6 hours of headache onset. It is important to remember that acute blood appears white on CT, but with time, blood becomes less white and becomes isodense. So, with time, CT is not sensitive. What about MRI brain without contrast? Even MRI is thought to be more sensitive than CT, but it is less available and takes longer time. What are advantages of MRI over CT? MRI is more sensitive than CT in detecting blood after delay presentation to the hospital, so it is more useful to use MRI after 6 hours of presentation. One of big advantages of MRI is the diffusion weighted image, DWI, which can detect early ischemic changes, which could be missed early by CT brain. So, after the diagnosis of subarachnoid hemorrhage is established, it is important to know the source of bleeding, I mean the exact site of aneurysm. That is why we use CT angiography. It doesn't look for blood in subarachnoid space, but it will show us the site of aneurysm in which vessel. What about MRI angiography? It is less available and it takes longer time, so unsuitable specifically when patients are unstable. Digital subtraction angiography. It is invasive technique as they will use catheter to enter inside the vessels. Even it is invasive, but it is better to delineate small vessels. One of the main advantages of digital subtraction angiography, it is a diagnostic and therapeutic tool at the same time. So at the same time on the table, we could localize the aneurysm and start endovascular therapy as coiling or stent to stop the source of bleeding. Before we see some images of subarachnoid hemorrhage, that is how normal CT brain looks like. As you can see, CSF space around the brain normally black due to presence of CSF fluid, as fluid appears black in CT. This patient has a history of head injury. CT brain shows a right temporal fracture with subarachnoid hemorrhage as acute blood appears white on CT. Another case of typical subarachnoid hemorrhage, as you can see in axial and coronal images, presence of blood around the surface of the brain extending into the interhemispheric fissure and Sylvian fissures. In this patient, you can see CT brain axial image shows subarachnoid blood is extending around the site of circle of Wells. This MRI brain without contrast, T1 axial and coronal images, and FLAIR axial image. Normally in MRI T1 and FLAIR sequences, the CSF appears black, but here you can see hyper-intense fluid in the left Sylvian fissure. These cases are examples of subarachnoid cisterns hemorrhage. In patient A, you can see blood anterior to the bones. This is prepontine cistern, and lateral to the bones, this is ambient cistern. In patient B, you can see blood anterior to the midbrain. This is interpeduncular cistern. This patient is an example of cortical or convexity subarachnoid hemorrhage. As we will see blood at the gray-white matter junction. A and B are CT brain images reveal cortical subarachnoid hemorrhage in the right frontal and left temporal regions. C is MRI brain FLAIR sequence shows high intensity changes for subarachnoid hemorrhage. D is MRI brain gradient echo or T2 star weighted image, which is highly sensitive sequence for detecting blood which appears black. Subarachnoid hemorrhage can extend intraventricular. As you can see here, in this case, the blood extending into lateral and fourth ventricles. As we said, CT angiography helps us to detect the site of aneurysm. In patient A, there is an aneurysm in left middle cerebral artery. In patient B, there is an aneurysm in the tip of the basilar artery. These images of digital subtraction angiography, in image A, you can see right internal carotid artery aneurysm. In image B, the patient underwent coil embolization. In this case, image A, digital subtraction angiography, shows anterior communicating artery aneurysm. In image B, the patient underwent coil embolization with complete occlusion of the aneurysm. So, let's recap what we have discussed in this talk. We discussed definition of arachnoid matter and subarachnoid space, different sites of subarachnoid hemorrhage, risk factors and etiology, clinical presentation of a patient with subarachnoid hemorrhage, diagnosis of subarachnoid hemorrhage, specifically imaging features. The references I have used for this talk. Here the references I have used for images. And finally, I would like to thank RadCast for giving me this opportunity to provide this talk, and I hope you have now better understanding of subarachnoid hemorrhage, specifically imaging features. Thank you.